Sullivan, are you able to share your slides if you want to get that started while I'm introducing you? We can do two things at once.
Oh no, let's see if we can get this to work. It was working. Let's try again.
All right.
Is that good?
We can't see them.
Okay, let me figure this out. This is
Well, while Dr. Sullivan is loading her slides, I'll introduce her. Dr. Katrina Sullivan, many of you who work at Harborview are familiar with. She is a board certified podiatrist, and she's the director of the high risk foot clinic at Harborview and takes care of some of our most complicated patients. She's also a staff podiatrist at the Pioneer Square Clinic and working with the Healthcare for the Homeless program. And she does a lot of work in our system and a lot of really fantastic education with all of us, in addition to taking care of, as I mentioned, really complex patients. So thank you so much for taking the time to come and speak with us today, and we can see your slides just fine.
okay, great. Thank you so kindly for having me. Thanks everyone for getting up early to talk about feet. It's one of my favorite topics. So I have no disclosures for this talk. Let's get to it. Hey, feet, they hurt. We know that approximately 60 to 75% of older adults will experience foot pain in their life. And in individuals greater than 70 years old, up to 36% of them will have disabling foot pain. So when the feet hurt, you can have decreased mobility, which increases the risk for falls, which is always a concern, decreases the quality of life, and it can be a warning signs of some medical conditions. Causes of foot pain, I tend to categorize them in my mind in order to keep track of them. They can be mechanical, rheumatologic, which is going to involve any forms of joint pain, which we'll elaborate on. Vascular causes of pain, neuropathic pain, and one of my favorites, toenail disorders. Mechanical foot pain, it can be deformity, such as bunions, hammer toes, just a very large foot in a small shoe. You can have keratosis, which can cause corns and calluses. Verrucas can be painful when people walk on them. And then something that the geriatric crowd will end up with is fat pad atrophy. The fat pad will thin throughout our lifetime, and it can make people feel like they're just walking the bone straight on the hard surfaces, such as getting to the bathroom or in and out of the shower. That's a foot that's going to hurt. So when patients take their shoe and sock off, and this is what I say, yep, that foot's going to hurt. So there's a lot going on here. There's a very large bunion due to the hallux valgus. There's a hammer toe, an overlapping hammer toe. You can see evidence where the DIP of the second toe has been rubbing on the shoe. You can have some crowding, some maceration, and pressure areas between the toes. Not all of our patients are going to be surgical candidates. Undergoing foot reconstructive surgery is a relatively big deal. People may have comorbidities that would affect their ability to recover from such a surgery. So then we need to start thinking about some other ways of managing the discomfort that the people experience. But when you're thinking through treatments, you want to be cognizant that although it sounds really nice to put a pad over the foot deformity, can that person then safely put that foot back into a shoe and not create some pressure injuries to the surrounding skin? So always be thoughtful when we're recommending things like protective padding. Sometimes really talking the person into using a different style or type or size of shoe is going to be the most effective treatment. A lot of our patients have underlying vascular issues, or they have atrophic skin to begin with, and their skin is not going to be very resilient or tolerant of excess pressure. Another form of mechanical foot pain, you can have hammer toe deformity. The toes are knuckling up. The weight-bearing pressures on the distal tips of the toes where it's not really designed to handle weight-bearing pressure. You can get a lot of keratosis or pressure injuries on the tips of the toes or discomfort. You can get direct pressure on the toenail itself, causing the toenail to change. And in this particular picture, there's a subungual hematoma. So I question if this individual either stubbed their toe, dropped something heavy, or perhaps is wearing a shoe that's not quite long enough. And so subungual hematomas can sort of lead you to question about the shoe fit or the shoe size. A nice simple way to help reduce some of the pressure at the tips of the toes can just be a little toe crest pad, otherwise known as a hammer toe pad. It can come, this is a leather one with an elastic strap that's adjustable. This is a silicone version. These are available frequently online. Occasionally they're out in the community pharmacies available for purchase. You put the loop on the toe, the flat part goes towards the shoe, the domed part goes towards the foot, the big part goes to the big toe, the little part goes to the little toe. They do come in left and right. They come small, medium, large. And this can just help alleviate some of the pressure at the tips of the toes. When people have some foot deformity, it can lead to a mechanical skin lesion. So just a corn or a callus is a normal skin response to an abnormal amount of pressure. Using a softer shoe, a softer insole, maybe a pad to try to relax the hammer toe a little bit can be helpful at alleviating this. But this has all the hallmarks of just a corn or callus. It's in a direct weight bearing area, and looking at the concomitant foot deformity, it makes a lot of sense. This would not be a verruca. The treatment for the provider can be a scalpel to debride this. I revoke patients' privilege to do home surgeries and no bathroom surgery. This would not be recommended for the patient. However, a pumice stone is a great tool for a patient to use to help manage that lesion. They want to use it with water while wet, and that's how they get the best use of the pumice stone to help reduce some of that keratosis. If patients have difficulty reaching their feet, you can even get a pumice stone on a handle, you can get a callus file, and that can facilitate the patient reaching their foot to reduce some of the keratosis. You can also soften corns or calluses. Eucerin's a great product, but good old-fashioned Vaseline works really well. There are some medicated, lovely creams and lotions not covered by insurance, sometimes a little financially out of reach of patients. Those are lovely if you can get them, but I'm a big advocate of just getting a big jar of Vaseline, getting it on the lesion several times a day, or at least once a day, to help keep it soft, and then patients can use a pumice stone at home. Soft insoles can be of benefit, particularly if fat pad atrophy is present. Patients often ask me, what can they do so that they no longer have foot pain when they're walking barefoot? And I say, put your shoes on. There's no real way to replace the fat pad as it wears out. And using a nice silicone or one of the gel versions of an insole, even in their house shoes, can give them a lot of relief. This is a closed cell foam made by a company called Spenco, S-P-E-N-C-O. And that's also something they can layer into their footwear if there's adequate space inside the shoe. But this can give people quite a bit of relief if they are having some plantar foot pain. This is a verruca, looks quite different than the classic corn or callus. This is responsive to topical treatments. You can freeze this. Freezing works best if it's been shaved down or debrided first. You can use a gentle topical acid if the patient is capable of applying it correctly. Resistant verruca, we will sometimes go to Aldera, which is a prescription cream that they put on several times a week. And when people take their shoes and socks off and I see this and they say their feet hurt, I say, yes, your feet will hurt. This is lack of mechanical debridement. This is somebody that was not able to take their shoes and socks off regularly. They depended on caregivers to do that. The caregivers would change the socks 2 to 3 times a week at most, not necessarily washing the skin in between times. The biggest treatment for this is soap and water. And so really just getting that dead skin cleaned off. It may take several tries. Literally in clinic, you can have the nurse, the medical assistant, or if you even have time, put the patient in some lukewarm, soapy warm water, use a terry cloth towel, anything that will wipe away is fair game, get some moisturizer back on the feet, even just Vaseline will work, and just try to make a realistic plan for the shoes and socks, that's particularly the socks, to get taken off every 24 hours for the normal shedding of the skin, and a good cleaning regime for just washing the feet. It's amazing what soap and water will do. And then when there's persistent dry skin and some cracking of the skin, it's good to step back and say, is this dry skin that's been resistant to cleaning and moisturizing efforts, or is there really an underlying tinea pedis? And this is a great example of moccasin foot distribution of tinea pedis. And if you just sort of just soften your focus of your eyes, you can almost imagine this patient's wearing a moccasin. So there's a little bit of redness, a little bit of peeling. There's the crusty dry skin on the plantar part, but this is actually moccasin foot tinea pedis. This will respond very well to topical antifungals. I typically will start with clotrimazole 1% cream. You can go to one of the other topical antifungals. They all work very similar once they're getting on the skin daily. And then the other washing and moisturizing efforts will work a little bit better once you treat the underlying tinea. No talk about mechanical foot pain is complete without at least touching base on heel pain. It's very, very common. 75% of all US-based people will have heel pain at some point in their life. Differential diagnosis is going to include plantar fasciitis. That is the most common cause of heel pain. It is often very uncomfortable, but in reality, in the big picture, it's self-limiting. It will clear up in 12 to 18 months without treatment, 95% of the time. Most people don't want to be that uncomfortable for a year to a year and a half, and so they do seek treatment. You can have subcalcaneal bursitis, which will be at the same location as the focal area of pain for plantar fasciitis. The caveat there is plantar fasciitis is classic post-static dyskinesis, so first step pain, where subcalcaneal bursitis feels best in the morning after people have been off of it all night, and then it is very uncomfortable the longer they're on their feet. You can have heel pain from fat pad atrophy, you can have neuropathic pain, you can have referred pain from an S1 radiculopathy. Little less common calcaneal stress fracture, although osteopenic, osteoporotic people that decide to take up a vigorous walking program to improve their health can get a calcaneal stress fracture. A little bit more rare is going to be osteomyelitis. There's usually some other chronic underlying things, neoplasms and Paget disease. Pretty low on the list, but if things are not responding to more typical treatments, then I'll go deeper into my differential diagnosis. The medial slip of the plantar fascia, or the large band, is going to insert into the medial tubercle of the calcaneus. That is going to be frequently the site of maximum tenderness. And it's just at that soft tissue bone interface where you see the majority of the inflammatory response. Although you can have fascial pain anywhere along the course of the plantar fascia, and I will typically palpate the entire course. I will dorsiflex at the ankle and then extend the toes upward. That puts the fascia taut, and then I can palpate along the course of the fascia to its insertion into the heel. But I frequently will start by asking the patient with one finger point to the area that hurts the most, and frequently they are going to point to the plantar medial heel. Arch supports are very helpful at overall treatment of plantar fasciitis. You're going to do your RICE, your rest, your ice, your compression, your elevation. But the arch support can take some of the stretch off the fascia, particularly at its insertion, and help with the healing process. Occasionally, we'll go to heel cups, particularly if there is a component of fat pad atrophy, and with subcalcaneal bursitis. Again, the bursitis is going to feel better in the morning, but worse as they're on their feet. So providing a little bit more cushioning right under the heel can be helpful. And supportive house shoes. I frequently will ask, what do you wear when you're indoors at home? People may come to clinic with lovely footwear, over-the-counter arch supports, even custom arch supports. They're doing great, but they spend majority of their day at home. And I ask them, what do you wear? Oh, I wear my hospital footy socks, or I wear my bedroom slippers, or I go barefoot. Their fasciitis or their heel pain is not going to improve until they're protecting their feet whenever they are out of bed. So I do ask those extra questions. And you can find lovely, lovely easy to put on house shoes that have these happen to have a nice cork footbed that's covered with felt, nice contour, good arch support. So those are the types of things we need to steer patients towards when they are grappling with some mechanical foot pain. X-rays, we all take an X-ray. It's nice to take an X-ray for something that doesn't sound quite right, or if it's not responding to initial treatment. You're going to look for a bone cyst. You're going to look for abnormality in the bone. This is not diagnostic. This has finding a plantar calcaneal spur, unless it's a very abnormal spur such as in Paget's disease, you are just not, this is not going to be indicative of how symptomatic or how slow or quickly somebody will recover. Patients love to see these and say, that's why I hurt. And it just doesn't bear out. Another form of mechanical foot pain can be a fibroma, and that is a benign soft tissue thickening within the plantar fascia itself, and people will feel like they're walking over a lump. We tend to try to manage these conservatively as long as possible. You can take an insole and put a little lipstick mark there and have the barefoot patient put their foot in their shoe on that insole to transfer the mark to exactly where the lump is and cut a hole in the insole, and that will just give it some pressure relief. Local excision of the fibroma is not advised because it tends to come back more aggressively when it's been disturbed. The surgical treatment of painful plantar fibroma is stripping of the entire plantar fascia. So we tend to not go there unless we have to. Joint pain. Lots of causes of joint pain in the foot. With 28 bones and all of those joints, there's lots of opportunity there. So, we always think about RA, we think about our seronegative or usually seronegative, crystal arthropathies and OAs. When somebody has advanced rheumatoid arthritis, and with the advent of the newer biologic treatments, we're seeing much less of advanced rheumatoid arthritis disease, but subluxation at the MTP level with fibular deviation. When a patient comes in and takes their shoes off and says, my feet hurt, and they show me these feet, I'm going to say, yes, your feet hurt. This is somebody who would do very well in an extra depth shoe so that I could do a multi-layer insole to try to provide some particular padding for the forefoot area. We need the width to accommodate the subluxed, particularly the first MTP, and they will frequently have very atrophic skin, so the skin's very, very thin. We use dactylitis. You're going to have your classic sausage digit. This happens to be somebody with psoriasis. The nail changes here do not represent fungus. This is psoriatic changes of the toenails, and a Kopner phenomenon where there's a little bit of shoe pressure at the fifth toe with a little bit overreaction of the skin due to the background psoriasis. But this is psoriatic arthritis. When we see single digits like this, you want to do your workup for your negative inflammatory problems. Enthesitis, which is going to be pain and inflammation accompanied by redness and some warmth at the tendon insertion. It can be anywhere in the body, but the posterior heel seems to be a pretty common spot. Our crystal arthropathies, you're going to have your nice monosodium uric spikes. This feels like walking on broken glass inside the joint. Red hot swollen joint that is not infection. Can be a little tricky getting fluid sample out of foot joints, particularly the big toe joint. It's already a sore joint. You have to walk the needle into the joint, which is not the most pleasant tap in the world. But crystal arthropathies tend to show up classically. They tend to show up suddenly, and it's a red hot swollen joint. The concomitant, the partner to monosodium urate is going to be your CPPD or your pseudogout. When you have osteoarthritis, particularly in the first toe joint, the joint does not flex and extend appropriately. This joint, there's pressure from the examiner, the finger is blanched, the toe is blanched, and this joint is not going to flex anymore. So this should go up to about here for normal gait. When our foot is on the ground and our heel is lifting, the big toe joint needs to extend upward. in order to accommodate normal gait. When osteoarthritis develops in the big toe joint, which is one of the most common sites for wear and tear arthritis in the foot, people lose that ability to extend the joint, which then affects gait, which can exacerbate other knee pain, hip pain, and just make them miserable. Not everybody's going to be a surgical candidate to fuse that joint, which is the preferred surgery for very active people. There are joint replacements. We do not recommend it for people that do a lot of weight-bearing activity, because the joint replacement tends to wear out prematurely. Joint replacements can work well for severe deformity associated with rheumatoid arthritis, but those individuals tend to not be heavy-duty ambulators at baseline. A good form of treatment, if people are not responding to just an over-the-counter arch support, is not giving them enough relief at the big toe joint, you can use a carbon fiber foot plate, and this is just snuck in underneath the insole inside the shoe. Again, making sure there's adequate room inside the shoe for all of these devices and the foot at the same time. But the carbon fiber foot plate can stiffen the shoe sufficiently that not much bending is being asked of the big toe joint. And this can provide some relief so people can get back to just their ADL type ambulation. Vascular causes. There can be lots of reasons that the vascular disease can cause pain in people's feet and lower extremities. The big one is going to be our peripheral arterial disease. So one of the big risk factors for development of PAD is going to be greater than 70 years old. Also, our 50 to 69 crowd is going to be at risk of developing PAD if they have any of these risk factors: diabetes, hypertension, hyperlipidemia, tobacco use, particularly smoking, and obesity. And once they start to have several of these risk factors, then their chances of having PAD go right up. But we often don't think about the role of venous disease in lower extremity pain. And we'll elaborate on that in just a minute. But for PAD, it's frequently asymptomatic. Greater than 50% of the people with advancing PAD do not realize they have it. They have not yet developed symptoms. Another interesting fact is about 30% of the providers don't realize the patient has PAD. So the patients aren't alone in not knowing. When symptoms do develop, it can develop as claudication. It can show up as pain when they try to walk. It can also show up as rest pain and tissue loss. We're pretty clear about identifying patients with PAD when they have rest pain and tissue loss. We're getting pretty good about when people are claudication, but we're not always so good at picking up when it's asymptomatic. Non-invasive vascular studies is a good place to start, and I recommend that you do the trifecta, that in addition to the AVI, which may be falsely elevated due to the calcinosis of the medial layer of the arteries, which is the non-compressible arteries. Also getting the toe brachial index, you want to see a value greater than 0.75, and the arterial Doppler, which can identify where a stenosis, high-grade stenosis is located. And I'm frequently looking for Doppler information, where if I can locate a high-grade stenosis or occlusion in a very proximal artery down into the lower extremity, that can be of benefit, because a lot of times those lesions can be opened up by our vascular colleagues. And even though there's significant persistent distal disease, it can increase the head of pressure of the blood flow into the distal foot so that I can get a wound healed, so I can get some relief of some of the discomfort and to buy some time. The invasive vascular studies, we tend to hold those and only use them for procedure planning. There can be some consequences to undergoing some of the invasive vascular studies. And so we really only take the risk associated with the studies if there is intention to treat. And interesting, when I was reviewing things for this talk, I came across a reference in the vascular literature, and they talked about the role of a comprehensive geriatric assessment will improve outcome in patients over 65 that have with planned vascular procedures. So I thought that was great. It's great to see. Initial treatment of symptomatic and confirmed claudication. So it's going to be all your cardiovascular risk factors. The smoking cessation is really big. And sometimes having data in front of a patient can finally nudge them over the hump on really trying to get rid of the cigarettes. Sometimes, we've been saying it, but sometimes having something in front of them will move that. But, managing the blood pressure, managing the blood sugar, addressing the lipids, antiplatelet therapy, if it's appropriate, weight reduction. And this is an interesting one, the supervised exercise therapy. And what was interesting about that is the literature shows that the functional improvement of patients with symptomatic claudication, but the functional improvement, the medical therapy that includes exercise, was more durable than the percutaneous interventions. So not all symptomatic claudication needs to have angioplasty. And actually, the data is supporting that aggressive medical therapy with the exercise component is actually of more benefit to our patients than having an intervention, vascular intervention, which is actually really reassuring. So just because somebody is uncomfortable and they're showing advanced disease, we can reassure them that we really need to try to manage this medically, that we can help you improve. And the improving tends to be longer lasting as long as they continue to exercise. I thought that was nice to see. The disease progression for claudication is actually quite slow. Only about 10 to 20% will develop worsening claudication, but 1 to 2% will go on to critical limb ischemia. When necrosis develops, and this is eschar, it's not draining, and it has sharp margins, there's some dusky changes in other parts of the foot, there's starting to be some skin slough. When necrosis develops, then we need to involve our vascular colleagues. And when we have necrosis, this poor individual started out with a heel decube, and they had underlying peripheral arterial disease, partly why the skin was less resilient to having pressure and why the decube could have formed very, very easily. But in an effort to treat the heel decube, the bandaging caused necrosis at the instep and pressure at the first MTP from trying to put a bandaged foot back into a shoe to go to medical visits. So we want to be very thoughtful when we're working with fragile skin without adequate blood flow, that even our treatments are not causing further problems. We want to be thoughtful that things like our bandaging techniques, or if we're going to put a bandage on a foot, that we're providing the patient with, say, a healing shoe or a post-op shoe, so they're not trying to put their normal footwear back on over bulky bandages, because we know that the skin is going to be fragile. It's not going to be very resistant or resilient in the face of additional pressure. So try to not make the treatment worse than the problem. Venous disease. So risk factors for venous disease are going to be advancing age, family history, ligamentous laxity. So individuals that have had hernias, perhaps a floppy flat foot, those individuals are going to be at risk of having some venous disease. So increased body mass, smoking, prior trauma or infection in the lower extremity. Classic example will be somebody that's had lower extremity cellulitis. DVT is really only possible for venous disease in about less than 30% of the time. So we always think, oh, people have venous disease, they must have had a DVT, and not necessarily, although it should always be considered. Telangiectasias at the ankle level can tell us that there is some venous incompetence going on there and some increased pressure. This is pathognomonic for venous hypertension. So this is going to be these he has a fancy Latin name, but it's basically these miniature varicose surface veins down at the ankle level. This is telling us that this limb has venous hypertension. This is a limb that would really do well to start into some graduated compression garments before they developed skin breakdown or worsening disease. Varicose veins, they tend to respond quite well to compression garments, particularly if they're symptomatic. These actually can be addressed by our vascular surgeons in the University of Washington medical system. The experts for addressing venous hypertension, valvular incompetence, and symptomatic venous disease is going to be our vascular colleagues at the U, which will also spill over into Northwest Hospital. The arterial experts tend to be at Harborview. So when I have patients that I need to get some help with the venous side of things, I will send them over to the vascular crew at the U. If I have arterial issues, I will lean on my colleagues here at Harborview. I can get rid of that. Okay. Pathognomonic for chronic venous stasis is you're going to have that that lipodermatosclerosis. That's where, the leg above the thickening of the skin is going to stay very bulbous and inflamed, and the skin actually becomes hard. It becomes kind of skinny. So we have a tendency to say, oh, well, the edema is well controlled here, and they don't need pressure garments. Well, they actually absolutely need pressure garments. Just because there's some advanced disease, you're still going to want to compress the entire limb to try to reduce future skin breakdown or heal current skin breakdown. And when someone comes in with a venous ulcer, this is a nice shaggy border. It's shallow, it has robust granulation tissue. There's the lipodermatosclerosis surrounding the limb. There's the hemosiderin deposits, the pebbly texture to the skin from the chronic changes. This wound needs compression, and these wounds can be painful. What you put in the wound can depend on how exudative it is. If it's pumping out a lot of serous fluid, you may need to do something highly absorptive over it. You may need to beat back some of that exuberant granulation tissue with some silver nitrate. But this wound, regardless of what you do in the wound or around the wound, is not going to recover until this limb is compressed. And this would be a great candidate for that multi-layer compression dressing. Conservative management is avoid prolonged sitting and standing. And I ask people, how many hours a day are you in your wheelchair? Some people, they get transferred out of their bed into the wheelchair and they're there for the day. So we talk about, how to get a break from the wheelchair, how to elevate their legs if they're in the wheelchair. Elevating the legs is conservative management. I also ask, do you fall asleep in your chair in the evenings? People are like, oh, I sit down to watch TV and then I wake up at 2 in the morning and toddle off to bed. Well, I'm never going to make progress in reducing their lower extremity edema if they're doing that much sitting. So we talk about the role of a footstool. Not everybody can always raise the legs above the level of the heart for classic draining of the lower legs. But falling asleep in a chair just makes the job of managing the edema that much more difficult. Encouraging walking or at least flexion exercises of the lower legs, and then using compression. But you do want to ensure that there's an ankle brachial index test within the last 12 months. This should be done annually if you're using compression. That's greater than, you want that reading to be greater than 0.6 to be safe. And graduated compression therapy, you really want to make sure that the hosiery is at the 20 to 40 millimeters mercury level. Multi-layered compression dressings can be used to shrink a limb in an effort to get them into a good graduated compression hosiery. And the compression dressings are absolutely golden when we're trying to manage skin breakdown. When to refer, if there's pain, the pain is just not responding to treatment. Arterial pain, absolutely, we should get our vascular colleagues involved to see if there's something simple they can do. But don't overlook the role of managed medical therapy. But we sometimes don't think to send venous disease for intervention, because sometimes there's some fairly straightforward things that our vascular colleagues can do to make it easier to manage some of the pain from venous disease, particularly if we have a recurrent, like we can get a wound to close, but we can't keep it closed. We could see if they can ligate a few vessels and just really make our job easier for long-term management. Neuropathic pain. Lots of causes. The lead cause of neuropathic pain tends to be diabetes, but you can also have toxic, so chronic alcohol or drug use. You can have infectious. We don't always think Lyme disease. Sometimes people relocate here from other parts of the country. And certainly metabolic, you can get some uremic pain. And we should not overlook the role of radiculopathy. I can have some diabetic patients that have painful peripheral neuropathy that's been, adequately managed, tolerable, not gone, but tolerable. And then the picture changes. And they said, the meds and the other things are just not working anymore. I have this new burning pain in my feet. And, I stop and I work them up with an EMG, and their spinal stenosis has now gotten severe enough that they have a radiculopathy layered on their diabetic neuropathy that was painful. We stop and address the spinal stenosis, and then they're just back to their baseline. They're like, oh, I'm back to my baseline. My meds now work the way that they used to work. So things can change. And when something that was adequately managing neuropathic pain is no longer managing it, I look for, is there another new cause of pain in these lower extremities that we need to stop and address? I always have to put a plug in for Charcot foot. So please, unilateral red hot swollen foot, particularly if there's change in shape of the foot, please get an x-ray, please. The bisection of the neck of the talus should be in line with the bisection of the first metatarsal. So this entire midfoot has collapsed, giving a rocker bottom foot. And these displaced bones have caused a hole in the skin from the patient ambulating on this neuropathic foot. So a concern. So any unilateral could be painful or painless swelling, particularly in the setting of neuropathy. An x-ray picture is warranted while you're ruling out infection and thinking through all your other causes of a red hot swollen foot. But do get the x-ray to make sure we're not dealing with a neuroarthropathy. I wonder where that red came from. Oh, well. Cam boots, while you're doing your workup on that red hot swollen foot, you can always protect the bones and put the person in a cam boot. These are something we can issue frequently in clinic. So something that's relatively easy to get for patients, and it protects the architecture of the foot while you're sorting out what's going on. Patients that do have a known Charcot foot where the foot has collapsed, longer term treatment is a brace that's made to them, and that's a Charcot restraint orthotic walker. That's what the CRO stands for. This is made by the prosthetics department. It has a bit of a rocker sole with a tread on it. The pink liner in there is removable, and so we, as the foot changes shape, or if we need to do a little bit, more pressure relief, we can change that liner. And people will sometimes be in these for months at a time while we are managing neuroarthropathy and trying to get it to consolidate. And the role of therapeutic footwear. Anytime there is a collapse of the foot or significant foot deformity where there has been some skin breakdown, we want to make sure that we are using footwear that has extra depth in it, that we can use a multi-layer insole to help offload pressure points. An infectious disease colleagues at the Madison Clinic here at Harborview sent a long-term diabetic patient back to me. His background peripheral neuropathy was suddenly no longer well controlled, and one of his digits was shrinking. Unbeknownst to the patient, he had a compound fracture or comminuted fracture of one of his digits. He does not recall what he could have run his foot into, although he has poor eyesight and he does have polyuria. So he gets up at night to the bathroom and admits he could have either hit the door jamb or the bedpost, as he frequently does. So when things change, when exam changes, x-rays can be helpful. The infectious disease specialist was very concerned, was this a new underlying infectious process? And I said, no, he has a broken toe. Toenails. I'd like to spend a few minutes talking about toenails. They can certainly be a source of pain. And not all toenail problems need the same treatment. So let's look at a few toenails. So this is a paronychia. It's a good example. There's the erythema and the swelling all around the skin fold. There's a little bit of exudate at the corner. It's not a very deformed toenail. It's a toenail that needs to be trimmed straight across. Perhaps this toenail was long and got shoe pressure, sock pressure, and caused a little break in the skin. But this is a paronychia, and paronychias need antibiotics. You can soak the toe 5 minutes at a time, 2 tablespoons of Epsom salts in a quart of lukewarm water. First choice is going to be a cephalosporin. If they're pen allergic, you can use some doxy. trim the toenail straight across, but this does not need to have the toenail removed. This does not need to have a partial nail avulsion. This just needs a little bit of local wound care and an antibiotic, and this will recover, and try to see if they don't make the same mistakes. This is an ingrown toenail that has already had a course of PO antibiotics and is not responded. And there's a big tell here. There is a granuloma. If you look along the medial skin fold of this nail plate, again, not a significant nail deformity, but this granuloma is telling you that there's a hole in the skin. And the nail is sitting in that hole in the skin, preventing the skin from closing itself. So the skin is growing new tissue in an effort to close the hole. So this toenail will not get better. The granuloma tells you this toenail will not get better with antibiotic. If there's enough other comorbidities, if the erythema was, extending proximal to the proximal skin fold, I would certainly cycle them back through perhaps another course of PO antibiotics for safety's sake. But antibiotics is not going to fix this. This one, you can soak the toe to soften it, but you need to take the nail out of the hole in the skin. So either a partial wedge resection of the nail, or sometimes just simply taking the whole nail plate out, letting this injury to the skin heal itself while the patient's just growing a new fresh nail. So this is not going to get better with just antibiotics. This sometimes gets sent to me as an ingrown toenail, and sometimes it's painful, but the surrounding skin looks great. Really no erythema, there's no edema, there's no granuloma. This is a mycotic toenail. Antibiotics is not going to fix this. Soaking is not really going to fix this. You want to trim the toenail straight across. You could pop this toenail plate off and treat the nail bed topically to get at the dermatophyte. The topical paint-on antifungals tend to not work. They just can't get through the keratin layers of the nail plate to get to the dermatophyte, which tends to live underneath the nail. Or if there's not contraindications, you can use a course of oral antifungals to treat this toenail, but antibiotics will not fix this. Your differential diagnosis on mycosis is know what you're treating. Are you treating mycosis or are you treating a psoriatic nail? Are you treating a post-trauma nail? Because repetitive microtrauma can cause the toenail to get discolored, deformed, and to get a lot of subungual debris. Onychogryphosis, which is just overgrown toenail, can again look mycotic. Recurrence rate post-oral treatment is up to 50%. So we are treating the current infection. It does not prevent new infections. Treatment failure can be inaccurate diagnosis. So I think if you're going to go with a course of oral antifungals, know what you're treating. I like to collect a sample of the toenail at the proximal leading edge of the nail plate. So if this is starting distal and it's marching proximally along the nail, I will deride all of the distal diseased nail and take a sample from the most proximal leading edge of the infection. I will send that down to the lab to have a fungal culture, but I'll also ask for a KOH. Fungus can be a little finicky to grow in the lab. If there's hypho elements or budding yeast seen on the KOH, but they just can't nudge it into growth on the culture, I will still consider that to be positive, and I'll go ahead and treat that with orals if indicated. But I do want to know that I was treating, fungus or yeast or saprophyte before I start with the oral antifungals. Because if you go through the 12-week treatment and then the 8-month, follow-up, and you have no change in the nail, were you really treating fungus in the first place? Concomitant taeniopedis, they absolutely have to commit to cleaning up the skin, because otherwise they'll just share the fungus right back under the nail if they don't clean up the skin. And the skin is best treated with the topical antifungal creams. And so you occasionally run into drug resistance. People that have been through several courses of oral antifungals and it's just no longer working because they just have either not cleaned their skin up or they just didn't change the habits that allowed it to start in the first place. This could send into ingrown toenails, but this is actually onychocryptosis. So antibiotics is not going to fix this. Soaking's not going to fix this unless you need to soak it to trim it. But you want to trim this straight across. You want to thin this down. This is actually a fibrous band of tissue that will sometimes form in the nail bed, and it causes the nail plate to tent up over it. So this is not mycosis. So, of course, oral antifungals would not change this at all. So trimming the nail straight across, trying to pack these corners with a little antibiotic ointment and cotton to push the skin away, because this nail got trimmed a little too short. So now the edge of the nail is trapped in the skin. You want to push the skin out of the way and give the toenail a clear pathway for growth. Thinning this with an emery board is important to get the pressure off the corners, or just, removing the nail, excising that fibrous band and letting the person just grow out a fresh toenail. But oral antifungals and antibiotics is not going to fix this at all. And this one is sometimes sent to me as an ingrown toenail. Unfortunately, this is a classic example of the onychogryphosis, or a ram's horn toenail. And this is just lack of debridement. When people come in and say, my feet hurt, I'm having trouble walking, I'm tripping more, and you take the shoes and socks off and you find this is a great place to start. Soaking's not indicated from the patient side, but it can be indicated from the provider side to soften this nail so that you can trim it. And you may have to take this off in sections frequently. If the person's apprehensive about having this debrided, I will take the nail off, quite distal to the digit itself, and then work my way back. But you would want to bring this toenail back to about here. This is your friend. Get comfortable using them. If anybody has questions on how to use them, come spend an afternoon with me in clinic. I'll be glad to show you. It's powerful what you can do to help patients if you trim their toenails. It can be very helpful. And emery boards. Pretty important to instruct patients how to thin some of those thick toenails, how to smooth some of the edges so they don't trim the toenail a little bit too short. I go through boxes and boxes of these in clinic just to smooth things down, to thin things down, and as part of instructing patients how to take care of their feet. So I have a one of these dealy bobs, but I'm glad to touch base on anything that people have questions about.
Thank you so much. We had a few questions that popped up in the chat. I can read them for you if you'd like.
Great.
So the first question was from Dr. Phelan. She wondered if, she says, who do you recommend for supervised exercise therapy for peripheral arterial disease? Do you have someone you recommend?
Oh, that's a great question. Pre-pandemic, the outpatient physical therapy has been fantastic. They can assess the patient on coming up with just a good home exercise program. Sometimes we've been using some home health PTs to go in and just really help the patient identify in their home what would be some safe ways to do the exercise. Doing almost like a cardiac rehab style PT is sort of not happening right now because of pandemic. I'm hoping that would come back in the future. But any of the outpatient physical therapy programs, could help us do that. But it's really imparting the fact that we need to get people moving, and that is a major form of treatment for our arterial disease.
Thank you. May Reed had a question related to compression wrapping. She said that she thinks that some nursing groups require an ABI greater than 0.8. And she was wondering about Coban versus Coban light, and if you had any recommendations regarding that for compression.
So great question about compression. Yes, a lot of the nurse-driven protocols require an ABI greater than 0.8, and that just gives them a little bit more latitude because compression wraps are a little bit operator dependent. So you need to have a little bit of wiggle room in there, that if it's not exactly smooth, that the skin is going to tolerate a little bit of excess pressure in a few areas. The Coban light will frequently get the job done, and it tends to be better tolerated by patients, particularly patients that are right on the cusp of can they tolerate compression wraps or not. So I think Coban light is just fine. The true 4-layer Coban wrapping is going to be for people that have a robust ABI and just really resistance, people like say the venous hypertension where the skin breaks down, and so or even for some lymphedema cases where we really need to shrink those limbs down. So I think Coban light is fine. And yes, some of the nurse-driven protocols need an ABI greater than 0.8. And if there's some question about whether there's mixed arterial and venous disease, sometimes getting the blessing from the vascular colleague, they can do a one-time visit and say, no, I think this person has adequate arterial inflow. I think you're safe to go forward. And that can also be of benefit if there's a question about the safety of using compression on a particular patient. But good question.
Great, thank you. Drew Hunter was wondering if digital blocks are used for toenail excisions, and if not, what analgesia, you know what I mean, is used.
Yes. So it's actually considered a form of torture to take off a toenail without blocking it first. So yes, digital blocks are great. And there's a few caveats. There's 4 nerve bundles that serve the tip of the toe, and I will instill the block back at the MTP level, so not distal at the side where everything's inflamed. So I'll get the 2 dorsal nerves, the 2 plantar nerves, and there is, if you go the last, let's save a little bit of the local anesthetic to just go sort of horizontal from the medial plantar nerve straight across the bottom of the digit to the lateral digital nerve. That seems to really help the very tip of the toe get nice and numb so that you can then do the work you need to do on the nail, whether it's a partial nail excision, whether it's excising the granuloma after you've taken some of the nail plate out of the way, or if you just want to pop the whole nail plate off. But it actually is all in the block. Once you get through the block, then the prep and the actual work on the nail plate becomes very easy. But that last little horizontal, from going from medial to lateral, you can either go forward and aspirate and then just leave a little bit of anesthetic as you're withdrawing the needle back out. But that last little bit really helps the block work well. Good question.
Great, thank you. The next question is, what causes toenail spooning, and is it preventable?
Spooning, we frequently think anemia. So they would, I would work them up to see what their iron stores are, to see if there's a reason for some anemia, or if you have a slow blood loss somewhere. So yeah, good question.
Great, thanks. And the next question is, which comes up for a lot of us, is if you have any ideas for nail care for homebound individuals.
Oh, I wish I did. I wish I did. I think there's a few providers in the community that were doing some in-home care. Let me, I don't know if that's changed in the epidemic, so I can reach out to our state association and see if there's still currently, there were some providers that were going in and doing some home care. Nail care has really been just a huge challenge during pandemic, because a lot of the nurse-run clinics that were in some of the local senior centers were suspended during pandemic response. So it was hard to get foot care at baseline, and it's been just much harder these last almost 2 years. So let me reach out to state association, and if there is a list of providers that are doing in-home care, I will try to get that back to the group.
Thank you so much. And another question is, Elizabeth Phelan said that a lot of patients say they go barefoot because their feet get hot and malodorous in house shoes, and she wants them to wear shoes for fall prevention in the fall prevention clinic, of course. Do you have go-to brands of shoes that are breathable so they can break the barefoot habit?
I enlist the patient in shoe selection. Shoes are so personal. I tell them to use antiperspirant foot spray if they're having trouble keeping their feet in shoes, because that will slow down the sweat glands. And especially if they say, oh, my feet get hot and sweaty in the shoes. I was like, well, I can help you with that. Find the good old fashioned antiperspirant spray and spray your feet and put your shoes and socks on. So I try to steer them towards breathable materials instead of plastics, although some people find Crocs to be very tolerable, particularly if the Crocs have lots of holes in the top, to let a little air inside. But I do enlist patients, and some of it is helping the patient understand the value of wearing the shoe. If they really want to put a little foot powder in there when they put their house shoes on, that's fine. Antiperspirant spray, a slightly different style shoe. but I try to have people go breathable materials if possible. Things like those cork footbeds with the felt uppers is good because that will breathe and adjust to temperature. Sometimes the cost of that is out of reach of patients. Sometimes being in an open back slide on shoe is not a good thing for that particular patient. So I think it's a good point of discussion. And trying to just say, this is the problem, we need you to be in protective footwear when you're out of bed. This will protect your feet from injury. This will reduce your risk of falls. And then I will turn that to the patient and say, what do you think will work for you? What's the best way to accomplish this problem? And try to enlist them in the problem solving to the best of our ability.
Great, thank you. We have a lot of our patients, because Medicare doesn't cover routine foot care, who end up going to local nail salons for their foot care. And I was just wondering if you have any thoughts and advice on that. Yeah.
Oh, in a perfect world. Yeah. When people ask me, is it safe for me to go to have, to a nail salon? And if they have medical disorders where Medicare would pay for them to have foot care in the clinic, and I think they're at really high risk, I try to say, I don't think that's safe for you. But those are people that we're going to be able to get reimbursed. And then we have everybody else. So I say, well, try to pick a salon where, they have clean practices, where they don't cut the toenails too short. I try to have the patient, don't let them round the corners of the toenails. And I also try to get some independence. So if the patient can do any kind of foot care, can they use an emery board? Can they, do some simple things? I try to encourage that as well.
Thank you. Thank you for answering all of our questions. I think, there's one more here. About specific shoe brands for plantar fasciitis.
Arch supports.
Arch
So things that have a good arch. So one of the challenges is that people have as many different size and shapes feet as there are people. So one shoe style is not going to work for every person. So I always try to say a shoe that has adequate room for your foot, has a good arch in it, or the manufacturer's shoe liner will pop right out and you can put more arch support in there and still comfortably have your foot inside. But for managing plantar fasciitis type heel pain, we really want to get them out of their flat house shoes, get them out of their flat shoes that they perhaps wear to the office. Something with an arch in it, something where the heel is just very slightly raised compared to the front of the shoe. So if you think about a lot of the running type shoes, there's a little bit of an inclination between the back of the shoe and the front of the shoe. Raising that heel just ever so slightly actually takes a little bit of the pressure off the fascia. It actually reconstitutes the medial arch slightly and takes a little pressure off the fascia. So for some of the women that are struggling with having a shoe that's supportive enough but still goes with, say, their work attire, if they're still working, picking a shoe that has a very slight rise to it can actually help fascia symptoms so much, but then really using a supportive house shoe. So either designating a shoe that's going to stay in the house that has a good arch in it, or getting like a slipper or stuff that has a nice firm footbed and arch in it. But if I say, oh, go get this one model of this one shoe, that's going to work for a tiny percentage of the people suffering from heel pain, and it will not work for quite a few of the others. So I wish it was simple to just say everybody go buy a Ford 150 and we all can haul bricks, but it's not so simple.
All right, we're at 9 o'clock, so I think we're going to have to stop.
Thank you all so much for having me, and Kate, thanks for the help with the tech side.
Oh, you bet. Yeah, thank you so much for taking all this time and answering our many questions that we have about foot care. Thank you so much. Have a good weekend, everyone.